The title of my talk is The Integration of Motivational Interviewing with Psychotherapies Targeting Shame-Related Psychopathology. In a strict sense, this is not really an assessment-only kind of presentation. It was placed in the symposium around assessment and interviewing, but motivational interviewing is actually meant to be an entire therapy approach. It does involve ongoing assessment of the patient's experience both in terms of the patient's motivation level and in the context of my paper, also the experience of the patient's shame level. So I hope you'll bear with me and pay attention to the therapy implications, which is really what I'm going to focus on here. Shame is an emotion that tends to be evoked in either social situations or situations in which people experience the possibility of an audience, someone looking at, seeing what the person is doing, and in most cases disapproving. So that when shame is evoked, the person experiences a kind of cringing away experience. They often will lower their gaze, physically pull back from others if others are present, so they shrink back. They will feel resigned, often deferent to others who show tendencies to be assertive, and they will often feel inwardly self-defective or insufficient or both. Shame as an emotion has been implicated, a frequent emotion, has been implicated in many, many different kinds of psychopathology. In some cases, it's much more clearly on the surface and an experience the person has quite frequently. And in other cases of pathology, it's a more underlying, perhaps unconscious kind of experience that does not show up so much on the surface. In many cases, if you have some acting out pathology, substance abuse, or other social norm violation kinds of pathology, the shame may well be there, but it's often under the surface and more effectively defended against. What I'm going to focus on today are therapies with the type of shame-related pathology that's more on the surface, readily seen and experienced quite frequently by the client. In earlier papers, Dr. Deborah Greenwald and I developed a theoretical model of shame domains that was outlined from an evolutionary perspective. Now, by evolutionary here, we're referring to the model of inclusive fitness that William Hamilton talks about. This is a model that was developed for evolutionary purposes for all species. And the basic principle is that all species behave in ways to help increase the chance that they can get their own genes into the next generation. So it's a reproductive kind of principle, and it's evolutionarily valuable, obviously, to reproduce effectively and to get one's genes into the next generation. The Hamilton focus on inclusive fitness is really an individually based kind of model. So that's the perspective, in a sense, that we're going to take here with our evolutionary model of shame-based pathologies. But it also has social implications, because people are social species. We need the contact with and connection with our groups to feel complete, and also to give us the advantages of developing ourselves into the next generation. So we developed an idea of 4 domains of shame experience that we think are important to consider. The first is conformity to social norms. So it's conformity. If one conforms to social norms, you can maintain your connection to the community. If you violate the norms too much or depart from them too frequently, then you can be excluded or ostracized, and then you don't have a chance for mate contact, mate selection, and successful reproduction. The second principle that we looked at for shame evolutionary advantage is pro-social reciprocity. This is the situation where people will give to each other, exchange favors, gifts, they help each other. I help you, you help me. And this maintains bonds and, again, allows for connection with the social group, possible good mate selection, and then reproduction, get one's genes into the next generation. A third area that we talked about was status competition. This is the competition aspect of all social societies, which goes right alongside the connection with the social group. So here people will compete for position, for advantage, for influence, for power, for monetary goods, and so on. And of course, the more advantages of that sort that one accrues to oneself, then the more advantage one has to give to one's children and reproduce in that sense successfully. So right alongside the need for connection and cooperation, there's also a status competition. And people can feel shame about not being good enough in those status and competitive areas and accruing enough advantages of their own for success. And the last area we felt was very important for shame-related pathology was sexual behavioral patterns. Either the person being too sexual or not sexual enough, or sexual in ways that are not appropriate or acceptable in the societal context where they live. Obviously, if they behave in a reasonably effective and assertive sexual manner by the norms of their own social group, they will be able to reproduce effectively. So we developed, along with this idea, some tactics for psychotherapy based upon this evolutionary perspective. And these included the following. First, pointing out the costs of current shame-affected maladaptive patterns. In many cases, of course, the client already knows these costs, but in some cases, the client is so prone to shame around the patterns that they've been showing and having difficulty with, they really haven't thought much about the costs of their shame-related pattern. So we suggested playing this out more clearly, making clear the costs for them. Second was challenging the beliefs underlying these patterns. This is obviously a cognitive behavioral principle. There are two general cognitive behavioral approaches. One would be the older one of Albert Ellis, where he would say, if a person has some strange ideas and is too shame-prone, ridicule them for it and shame them out of their shame. We believe that doesn't work at all. It tends to make people more shamed, so that makes the situation worse. The more recent approach in cognitive behavioral terms would be that of Aaron Beck, in which one is trying to be gentler about it, but still points out the errors in cognition. And that's generally what we recommended in our previous papers. A third part of our recommendations for therapy was urging experimentation with new behavioral patterns and a graduated exposure to some of the shame experience, but in small amounts and in ways that were manageable and testable to see if the person really had to be ashamed as they imagined in situations where they would change their behavior patterns a bit. Now, unfortunately, though, trying to put these principles into practice with what I consider to be a kind of typical, on-the-surface, shame-prone person proved in many cases to actually seem to make the person not get better, at least not very rapidly, but rather to increase their shame experience. So it had a paradoxical effect and a negative one. When I speak of the typical shame-prone patient here, I'm talking about someone who would score very highly on a scale that I developed called the Personal Feelings Questionnaire 2, which assesses shame and guilt, affect, and experience. And these people would score very high on the shame scale, meaning that they very typically experience these shame emotions. They also tend to be people who are shy, generally quiet, reticent, non-assertive. They would tend, in most cases, to try to avoid high emotional states, both positive and negative, but particularly angry, negative ones. They tend to be yielding to others. They can get intimidated very easily. They feel readily that the whole self is either bad or defective, and they get depressed pretty easily as well. There can, of course, be people who have these more unconscious kinds of shame experiences, but these on-the-surface types are the ones that really score high on that scale and are the people I'm focusing on here. So the effects that I would find in trying to apply the previous principles recommended for therapy would tend to produce one of two outcomes, neither of which was very desirable. The first was that the patient would get more quiet, relatively silent, say less in therapy. In the parlance of slang in the US, they would clam up. The second outcome, which was in some sense even worse, was that they might essentially withdraw from engagement with the therapy so that they would really not say much at all, and in many cases actually leave the treatment, so nothing could be done further. So obviously something else is to make these patients stay in treatment and get better. And I think the motivational interviewing paradigm that I want to try to integrate here is something that can be helpful in that regard. Motivational interviewing, which is also referred to as MI in short, has recommendations that try to avoid the danger of inadvertently shaming the client and thereby increasing resistance and avoidance of the treatment. MI was originally a treatment developed to work with substance abusers who were noted in many cases to not really truly share the goals of addiction control and eventual abstinence that were advocated by their therapists. So in many cases, the therapist would assume the patient's really here to work hard to change, even if they voluntarily came. The therapist, I think, would be assuming too much there. All too often, the therapist would assume the substance abuser shared the same level of desire for change that the therapist did. The client was essentially fully invested in change in the mind of the therapist. Thus, the therapist would be recommending actions right away, such as the modification of erroneous cognitions and the carrying out of homework behavioral assignments consistent with the goal of abstinence that were not really fully shared by the client. When therapeutic compliance was less than complete, the therapist could end up feeling angry. The therapist could withdraw from helpful engagement with the patient. They could pronounce the client then eventually of low motivation and basically untreatable, and allow the therapy to founder. Motivational interviewing that was developed originally by William Miller and Stephen Rolnick highlights the authentically ambivalent state of substance abusers, every addict, and further has extended that notion of real ambivalence in all clients to all kinds of pathology. And I think that's something very important to keep in mind. One might say then that the first key idea of motivational interviewing is that patients are often highly ambivalent, and that all patients are ambivalent to a significant degree. Now, interestingly, if you think about it historically, this is a principle of psychoanalysis and all psychodynamic therapies, which in these days of cognitive behavioral therapy dominance in the US at least, often really doesn't get the focus that it probably deserves. Patients are ambivalent. We need to know that and keep it in mind. So I think the mistake of many therapists and the seed of therapeutic disillusionment for client and therapist alike is an insufficient appreciation of the extent of the patient's ambivalence. So from this issue, we might then keep in mind the first principle of MI, and that is the use of frequent, empathic, reflective listening responses that are attuned to both poles of the client's ambivalence. This is shortened to the principle of express empathy. For example, if you're working with an alcoholic, you might say, you really want to stop drinking because it makes your thinking fuzzy and your body fat, based on what the patient said. But there's that wonderful relaxation and ease about the world that the booze gives you. So you get both poles of the ambivalence there. Now this, of course, is the cardinal principle of Rogerian client-centered therapy, to empathize accurately and communicate that accurate empathy to the client in the context of positive regard. So that's why it's shortened to express empathy, but it really means express accurate empathy with positive regard. Some of the MI people have said that their therapy is really Rogerian therapy with a twist. So the Rogerian principle is the central principle, to empathize well. But there are other principles they add which are the signature aspects of MI. And that's what they're going to add in. And I'd like to think about how we might do that with these shame-related clients I talk about. Now the twist is to go farther than just reflecting the patient's ambivalence. Essentially what the MI therapist tries to do is to elicit the patient's motivation and desire for change and inclination toward change by asking a number of open-ended questions, which are actually meant to go far beyond the ambivalence. They put it in terms of eliciting change talk. Patients who have this ambivalence, of course, will talk about the desire to change, maybe some things about how they could change or would like to change. And those are the things that the MI therapist tends to focus on after an initial period of pretty much basic empathy. The three other principles of motivational interviewing that we should keep in mind beyond the express empathy are the following. The first, or the second in their list of four, is developing discrepancy. This means developing the patient's awareness of discrepancy between their present values and their present behavioral patterns. So they may have a value, for example, of feeling they should be rightfully assertive and get what they deserve when they've been discharged, say, for a credit card bill, something as simple as that. So they have a right to be able to assert themselves and get the refund they deserve. But if it's a typical shame-prone patient of the type I'm talking about, they will also feel very reluctant to do that because it's painful to produce anything that smacks of a confrontation. So their present behavior pattern is the avoidance of confrontation, but their present value is, I should be able to assert myself. And that's a difficulty for them. So to develop awareness, increased awareness of this discrepancy is what an MI therapist might do by asking about the difference between the value and the behavior. The third principle of MI would be rolling with resistance. Rolling with resistance is based on the idea that resistance is normal. If we assume that all patients have this heightened ambivalence we've talked about, then obviously when you head in one direction, the ambivalence you feel will tend to pull you back in the other direction. So if you're heading toward change in one sense, you'll also have resistance to that change. So what the MI therapists are saying is that when you hear the resistance coming up, don't keep pressing against it, but essentially empathize with it. Accept it, see it as normal, and perhaps even in many cases, actually help the patient voice the advantages of having their psychopathology. What is the advantage, for example, of drinking? It might be that sense of bliss that you get when you've drunk a lot and gotten drunk. Or it may be the comfort you feel when you avoid the confrontation. But you should be ready to empathize with that advantage to the pathology, as well as pushing to change it. So the rolling with resistance is a kind of another level of empathy. And the last and fourth principle of MI is supporting self-efficacy. This is to both heighten the patient's sense that he or she can make the changes they would like to make, and also to anticipate with them some of the difficulties they might experience along the way, but how they might get around those difficulties in their change process. All of these last three, developing discrepancy, rolling with resistance, and the supporting self-efficacy, can be promoted by what are called open-ended questions. Questions that tend to focus the client on those areas where change is needed, but only at the speed that the patient feels they're ready to deal with it, essentially. Some MI therapists then will say that the first part of therapy is the empathy, express empathy principle. The second phase of therapy are all these other things with an emphasis on the open-ended questions, focusing on change areas to elicit change talk. So let's say we have a patient, bizarre, who is so painfully shame inhibited that she finds it difficult to walk across the room. She feels that people are looking at her, thinking negative thoughts about her, having always a negative evaluation of what she does. She completely tries to avoid confrontation, even making her presence known, because it can be something that can be criticized and induce shame in her. So in that kind of a context, you could push to develop discrepancy by asking questions about how that doesn't correspond with her desire and feeling that she has a value. I should be able to walk across that room with no problem. But if you keep asking about that problem, you may actually be increasing her shame experience to the extent that she can't really bring out her change motivation very effectively. So with that kind of example in mind, I would like to suggest some alterations in integrating motivational interviewing with these shame-prone patients I'm talking about and working with them. I have two principles that I'd like to suggest for working with this kind of typical high shame patient. First of all, it would be to have a higher ratio of express empathy kinds of statements versus the open-ended questions that are meant to elicit change talk. depending on which MI therapist you ask, you'll hear that the percentage of empathy statements, Rogerian reflections, versus other kinds of statements by the therapist should be on the order of 1 to 3 or 1 to 2, so a third to a half. I would suggest in the case of these high shame-prone patients that probably the principle of empathy statements should be much higher, especially in the beginning of treatment. So I would say 50% probably at least, and perhaps even 3/4 in the beginning. Now, as time goes along and the patient becomes more comfortable and can talk about the shame-related experiences, you can bring down the level of empathy statements and increase the level of the open-ended questions meant to develop the discrepancies and also bring about some of the self-efficacy change. So I would say more empathy, less open-ended change talk kinds of questions. So for the typical change client, depending on how serious the change situation is and the shame experience the person has, I would say that the therapist should always caution himself or herself not to pounce too quickly when they hear something from the patient that sounds like change talk. I think that's a tendency my therapists have nowadays a bit. They want to get to the semi-directive part of the treatment and get change to happen. So if they hear the patient start to talk about change, even one of these highly shame-prone patients, they will pounce, they'll start asking all kinds of questions about how to get things done, how to change. And that tends to increase the shame experience for some of these clients. To give you an example, if you have a client with a sexual abuse history who finds it very difficult to talk about sexual experience and the desire for a better sex life with her husband, even though her current value is that she should be able to do that, if you start asking questions about how to bring about change or making suggestions in that direction, what you're going to get is a patient who tends to shut down, withdraw, get very uncomfortable. So I would suggest that in addition to increasing the empathy, a second principle of a patient, of working with a patient who is high shame prone in this kind of context with MI, would be to constantly monitor how your open-ended change talk questions are affecting the patient. And signs that you're in trouble and need to do less of that and drop back to the empathy position would be the following. You might see the patient get quiet. You might see the patient get sort of agitated in a subtle way. You might see the patient show some mild irritation or anger. And it can be very subtle in these patients because they don't like to get angry. Or it could be something in the way of lateness, tardiness that they haven't shown before. Missed appointment, unexpected lateness, something that shows reluctance and withdrawal. So if you see something like that happening, I think the second principle here on monitoring the shame experience of the patient would be to stop the change talk questions and go back to just empathizing for a while. So then the patient, when she starts to talk more in ways that imply they're ready for change, then you can start to ask more of the open-ended questions. So I think for these highly shame-prone patients, the key would be then to empathize more, to roll with resistance more, and to do less of the open-ended change talk. But I think the MI approach can still be valuable if you do it, in a sense, slower than the way MI is often done with other cases. Thank you.